Good morning, Ben.
Good morning, John.
How you doing?
Hi.
How many today?
Today is Sunday.
Okay, so
Yeah.
day off.
Just one this morning.
Oh, okay. So in China, Sunday's a slow work day?
Yes.
Okay, let me get this. I'm sorry, let me get this. I'm repeating myself here at the, let me get off this.
Dr. Marco.
Hi.
Hi. Nice to
meet
see
you.
you. Yeah.
Nice to see you too.
So you are in Italy?
Yeah, I work in Italy.
Okay.
How can I say, in North Italy.
Okay.
Yeah.
Nice to see you.
Nice to meet you too.
Mhm. Hi, John. So do you notice Atul Goel changed his hospital, moved to another hospital? John?
I'm sorry, Ben,
Okay.
I'm sorry. Dr. Goel moved to another hospital?
Yeah, is it true? Because
I don't know. I don't know. I'm gonna ask
Okay.
him because he did send me yeah, different information of hospital
Okay.
he's working at. So yeah, I'll ask him.
Yeah, his previous hospital is the King Memorial, KEM, King
Okay.
Edward Memorial Hospital.
KEM.
Not this
I
one.
guess it's a chain of hospitals, the KEM, because they have them in other parts of India too. There we go. So everything again, Marco, Dr. Ben, Marco gives an excellent series on peripheral nerve injuries. That's his area of expertise.
Mhm.
So we're going to try to get him to do some in Latin America, peripheral nerve, because as you know, most general neurosurgeons don't get much education in peripheral nerves.
Yes.
So I think that's a good niche for Marco to teach.
Great.
So,
It's my great interest peripheral nerve surgery. So I'm very happy to share this, even because it's a topic that is not well known by a large part of neurosurgeon, unfortunately.
So mostly for the pediatric patient, the children's, like palsy for the peripheral nerve.
You mean obstetric brachial plexus palsy?
What kind of surgery do you perform?
Oh well, actually, I don't care pediatric surgery in this field. Anyway, usually the first step is wait and see. You put a brace and you recheck the baby after 3 months about. In the case you don't have any result, is advisable to perform a triple transfer. So you perform a transfer from the spinal accessory nerve, branch of the trapezius, to the suprascapular to rebuild the shoulder flexion, extension, sorry. And you perform also a transfer from the from the tricep muscle branch to the circumflex nerve to rebuild the extra rotation, and also overling transfer to rebuild the elbow flexion. So that means you got a large successful outcome in rebuild the main function of the upper arms.
Okay, thank you.
Well,
So normally this kind of surgery was performed in our hand surgery department. We have a hand surgery department.
That's
yeah,
a
it's
constant battle, right? A battle between departments of plastic surgery. Takes like what is that injury in the wrist? Carpal tunnel syndrome. Carpal tunnel. You know, the neurosurgeons want to do it. The orthopedics and hands.
yeah, it's a sort of borderline
indications,
territory.
huh?
Yeah.
Yeah.
Same in China. Same in China, Ben, or hand surgery is really strong.
Our hand surgery department is quite strong.
Very strong. Okay.
Yeah.
Very good. It's a great. Neurosurgery is definitely a multidisciplinary team needing, because we got many structure like also vascular and joints. So it's definitely needed multidisciplinary teams when you perform peripheral surgery.
Yes, actually, my anastomos for the small vessels also trained in the hand surgery department. Yeah, they have a very nice laboratory.
Good, very good.
Mm-hmm.
You know, Ben, eventually I'd like to get the hand surgery surgeons of the world together. I got the domain name hand.tv. So if you know any hand surgeons that like to do Zooms, they're welcome.
Okay.
Just send them to me. Send me, and I'll write to them and tell them what I want to do.
Okay, great.
Hi, John.
Hey, how you doing, Hashad?
I'm fine. Where is the king?
Say hi to Ben.
Hi.
Hello, Ben.
Hi,
How
Hashad.
are you? I'm
Fine.
fine. Just answer to your question to whether Atul Goel has changed the hospital. He is retired from King Edward Memorial Hospital as the head of the department.
Okay.
He's still continuing with the private like Lilavati and other hospitals.
Okay.
He has retired as a head of the department.
Okay.
So he is working in private setup more now.
Okay.
Because we are in the same hospitals, so we know
that.
Yeah.
So now you work in the same hospital?
Yeah. Since quite some time, Atul worked both in private setup as well as the government setup.
Okay.
So from government King Edward Memorial Hospital, he has retired.
Okay.
As a professor.
Okay.
Yeah.
So how about Abida?
Abida is still
here's Abby now. Abby.
Hi, Ben.
Hi.
She's there. She's there.
Hey, how are you?
I'm fine.
So you also moved to the new hospital?
No, I'm still.
No.
I'm
okay.
I'm still there, but we are also working in another hospital together. So.
Okay.
Yeah.
Great.
How you doing, Abby?
Hello, Victor.
Yeah, I'm good.
Hello.
Hi,
Very nice to see you,
Victor.
Professor.
Hi, Victor.
Welcome, Victor.
Shubin. Hello.
Hi.
How are you?
Fine.
Hi, Victor. How are you? Long time no see.
Yeah. Yes.
Oh.
Very nice to see you, dear friend.
How you go?
Yanni, how are you?
Hi. Good.
Hi.
Hey, how you doing, Wanli?
I'm in Beijing. I just back from Kunming.
Okay.
Long time. I stayed there for almost 6 months, I think.
Oh,
yeah.
Okay.
Yeah. Okay. Yeah. So, great. So now we have Dr. Goel, right?
Goel,
Yes.
correct.
Actually, next week there will be a ACNS meeting in Shanghai, right?
Yes.
Okay. Yeah. Good. But mostly it will be it's like an online meeting, I guess, right?
Yes. Yes.
Okay. Do we have any foreign guests? Maybe
No,
if-
because the anti-pandemic policy is still very strict. Yes.
still 10 days.
So yes,
Yeah.
the quarantine for 1 week. I don't think they would
The
accept.
king has arrived.
Hi, Professor
Hello,
Goel.
hello,
Hi.
John. Hello, Ben.
Welcome.
Hi.
Very big honor to be with you. Ben, how are you? Everything okay in
Fine.
China?
Fine. Yes.
Very good.
Hi,
very
Atul. Everybody is waiting for you here.
good. Okay.
Yeah.
King has arrived.
Hello,
Yeah,
Professor
Victor's here.
Atul.
Victor's here too, Atul.
Thank you.
Professor
thank you.
Atul. Hello, how are you, Professor Atul?
Oh, Victor.
I'll
Nice
see
to
you.
see-
I'll see you in 2 weeks more in Athens, Greece.
Yes, yes.
You going to
yes.
Athens? You going to Athens, Atul?
Yeah. Let
Oh,
us
wow,
see.
you're going to South America, Europe now?
Okay.
Wow. It's like Hannibal or Marco Polo. Are you ready to start, Atul?
Yeah.
Okay, let's go. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach, home of Neurosurgical TV. We are honored to be televising the Chinese Neurosurgical Journal Webcast twice a month. And today we're featuring Atul Goel, a gentleman I've known for a while. He's a worldwide educator. And I'll let Ben Zhu, a big neurosurgeon from Shanghai, give the formal neurosurgical introduction. Good morning, Ben.
Good morning, John. So Professor Atul Goel is a very experienced neurosurgeon, and he is my idol. He worked so hard, and when I visited him in the King Edward Memorial Hospital, I was astonished because he can operate 1,500 operations in 1 year.
Wow.
Yes, so he is a really a giant in neurosurgeons world. Yeah. So now Professor Goel just retired from the King Edward Memorial Hospital and moved to a Lilavati Hospital. Is it correct? Okay. Now let's give the time to Professor Atul Goel, and I'm always learn a lot from him.
Thank you, Ben. And thank you, John, and the Chinese Journal. And I convey my best wishes to this journal. I'm sure this journal will eventually be extremely popular and powerful. And to talk with Ben and to hear those nice words is it is a great honor for me. Ben is doing very beautiful work, and he's teaching the whole world the art of bypass and other vascular neurosurgery. And I'm extremely proud to hear whatever he has said. As far as I am concerned today, I am going to talk on skull-based surgery. Basically, it is a summary of my 35 years of experience in the region of cavernous sinus and around the cavernous sinus, and how I see these tumors, how I visualize these tumors, and how I plan these tumors. This is based on my published work. And as we all know, the publications, we are talking for a journal. Publications are important, and every sentence that I'm going to talk before you is all published. And that is the beauty of my my presentation today. So dura has got very intimate relationship with all the skull-based tumors, and we have to understand that relationship. And only after we have understood that relationship, we can operate on these tumors. Needless to say that if we have to do complex neurosurgery, we have to have the understanding of skull-based anatomy, not only the normal anatomy, but also when there is a tumor, when there is a displacement of the nerves, when there is displacement of the arteries, displacement of the structure. More important is the artery will be displaced, the nerve will be displaced, but the dura will remain in its absolute divine position. And that is what makes the surgery, the planning of surgery, discrete for all tumors. So this is my, I'm in this subject for several years now. And in 1996, I wrote this book, Neurosurgery of Complex Tumors and Vascular Lesions, with Professor Kobayashi in Japan. And if you see this image, you see in 1996, there is a complete petrosectomy done, carotid artery is displaced, facial nerve is displaced, trigeminal nerve is displaced, and the whole region is exposed. So this was the picture in 1996. Before I go into the subject of complex neurosurgery, I want to give a message to young neurosurgeons in particular, that we have to understand the anatomy of the area, the philosophical issues related to the tumor, to the subject, and philosophy of the entire region. For instance, cavernous sinus is there in the base of the skull. Does cavernous sinus have any function? Is it just a venous sinus, or is it having a function? We realized, and we have written several articles on this subject with my teacher, Professor Kothari, several articles, and I wish that you read these articles about what is cavernous sinus and what are the functions of cavernous sinus. And we realized that the more the eye movements of an animal, like a deer, the eye movements will be very brisk because the deer has to look in front, deer has to look behind, it has to run, it has to cross bridges, and it has to play safe from the lion, which is attacking from behind. So the eye moves very briskly front and back and circumferentially. On the other hand, the tiger has to just look in front and attack. It is not bothered on what is happening near the tail or who is coming behind or who is coming from the side. So the eye movements are very restricted. 70 degrees is the angle of vision. Here it is 180 degrees. So we had written about it that more the eye movements, more bigger is the cavernous sinus. Cavernous sinus is indeed small in lion and tiger, and in human being 120 degree is the vision in the human being, and that the eye movements are restricted as compared to a deer or a fish. So the fish cavernous sinus is proportionately bigger. So this is what we had speculated. Also several other speculations, like does cavernous sinus has a role in eye movements, in vision, in temperature regulation, in cerebral blood flow, in hemostasis, and several other functions, which I wish that you read these articles, which are quite beautiful articles in my estimation. So cavernous sinus, we had mentioned for the first time in the literature that it is, when there is a cavernous sinus thrombosis, the eye movements may be disturbed, the vision may be disturbed when the optic nerve is present, when the third, fourth, sixth nerves are present. So we had mentioned that it has big role in eye movements, it has great role in vision. Actually, cavernous sinus supports the eyeball, it supports the retinal artery, which is devoid of muscularis. The muscular layer of retina artery is not there, so any pressure on the eye can damage the retinal artery. Cavernous sinus supports that by quick venous drain off. And the hydrodynamics of the eyeball, the vitreous humor, the lens, the aqueous humor is all supported. The quick drain off that cavernous sinus presence has a role in hydrodynamics. So there are several speculations that we had discussed, and I wish that you please read those speculations. Pituitary gland is neither in the skull nor outside the skull. It has a special location by the side of cavernous sinus, by the side of paranasal sinus. So when the air goes in the nose, it remains hot or cold in the nose, but as soon as it goes beyond, the temperature becomes normal. As soon as the water you drink is hot or cold, but as soon as it goes beyond into the esophagus, so this is a big temperature regulator or air conditioner of the body. And this paranasal sinus is very close proximity to the cavernous sinus, to the pituitary gland, and this relationship of external environment with internal environment may have some role to play in the function of pituitary gland. So these kind of speculations we have discussed, which were never discussed earlier in the literature. Another beautiful thing which is taken from Arabic literature is alum al-dimag. It means that the meninges are the mother of brain. Meninges are the mother of brain. Dura mater. Mater means mother. Dura is durable. So dura mater. Dura is mother. So we have to, as surgeons, we have to respect the dura during surgery because the tumors respect the dura. So dura is a compact. Dura makes a very hugely compact intracranial cavity. No virus or no bacteria can traverse the skin, and this dura is a protective membrane. Dura is stronger than the skull bone. Dura is stronger than any other membrane of the body. Dura is the strongest membrane of the body. It covers the brain and it goes along all the arteries and nerves. The dura does not end. The nerves do not make a hole in the dura. They do not pierce. So dura is a very big protection for the brain. So I have been working on cavernous sinus for the last 35 years, and various articles we have written on this subject. And some of these articles I will like to show you. And we had discussed that how we can diagnose tumors on the basis of the meningeal architecture. You see, meningeal architecture, how the dura is displaced, how the carotid artery, see arterial displacement, how by arterial displacement, meningeal architecture, you can diagnose the tumor, that this is a pituitary tumor, this is a cavernous hemangioma, this is a trigeminal neurinoma, this is a chordoma. So when we go for surgery, now, of course, the matters are different, but 25 years ago, it was not so easy to diagnose a tumor and then to treat the tumor. So surgery for chordoma is different, surgery for meningioma is different, surgery for trigeminal neurinoma is different. So before operation, you have to diagnose the tumor on the basis of meningeal relationship, on the basis of arterial displacement and relationship. So these were very important papers in the milestone papers in the history of cavernous sinus surgery. So this was the article as to impact of arterial displacement. Some tumors encase the carotid artery. Some tumors displace the carotid artery. So this tumor is different, this tumor is different on the basis of how the arterial relationships, how the displacement, whether it is squeezing the artery, whether it is encasing but not squeezing, we can diagnose, we can have an impression about the consistency of the tumor, and then we can plan the surgery. So this was my article in 1998 as to how to diagnose and then how to treat the tumor. So I worked in KEM Hospital, which is one of the biggest public hospitals in this country, which gives completely free treatment to the patient. And I was the chairman of this department for 24 years. And this is, you see, in 1993, gave me an opportunity to do very complex cases, very huge number of cases. So that was my power, and that remains my power. You see, this was the case I did in 1999. You can see the extent of petrosectomy and extent of tumor resection, and the beautiful, and I have heard that this lady was blind before operation, still remains blind, but still is alive after several years of surgery. So do good surgery is in our hand. We can create complications that is not in our hand, but we have to see that there are minimized complications. This subject is complex, this subject is difficult, this subject is dangerous, and we have to understand this. In 1995, I removed this tumor going in orbit, going in cavernous sinus, going in petroclival area towards the brainstem, and a meningioma. I don't think this patient survived for too long. This is another tumor, small residue, 1995, about 30 years ago, I operated this patient. And you see the result, there is small residual tumor after several years of surgery. This is another tumor I operated in 1997. So essentially, if you have to do complex tumors, you have to be in it. You have to know how to demolish the tumor, how to break the tumor, how to dissect in the subarachnoid space, how to dissect the carotid artery. More importantly, we have to know the membranes. We have to know the dura, the relationship of the dura. The tumors, benign tumors, remain confined to the dura. Dura matter or mother. So people who are good or who are benign will respect the mother. Some people are not good, they do not respect the mother. I call those tumors as malignant tumors. So on the basis of dural relationship, you can do various kinds of understanding of the tumor and surgery. So in 1997, for the first time in the literature, we described extradural approach to tumors. You see, Vinko Dolenz, we have heard about his work on several occasions about aneurysms, intracavernous, and how he did extradural. So on those concepts, this is the first paper where we mention extradural approach to tumors involving cavernous sinus. And this tumor is a very important cavernous sinus tumor, the only primary intracavernous sinus tumor. This is the most difficult neurosurgical tumor, most benign neurosurgical tumor, most vascular tumor, and this is common, not very common tumor, but many cases have been reported from China. This is cavernous hemangioma of cavernous sinus. This completely respects the dura. It is completely within the dural confines. It goes towards the orbit, goes towards the Meckel's cave, intercavernous sinus. It goes towards the contralateral side in the intercavernous sinus venous complex. And it encases the internal carotid artery. So this relationship is quite a very common. It is not disturbed no matter how big the tumor becomes. So in 1991, we did this resection of the tumor, the most vascular tumor. First, I had come from the nose, and then we realized that it is a hugely vascular tumor. I packed it, and then I came from here and removed this tumor. I am not sure if there is any case of cavernous hemangioma resection before 1991. So even if the tumor becomes large, it respects the dura. It remains within the dural confine. The third nerve, the fifth nerve, the fourth nerve are displaced along the dome of the tumor. The sixth nerve is displaced on the inferior dome of the tumor. So identification of the nerve and working within in a bleeding territory is the key. Because if you can remove this tumor, you can give new life to the patient. And we have described for the first time extradural approach to these tumors in a Japanese journal I described in year 2000, 23 years ago, with my experience with 13 cases. So extradural cavernous sinus is an extradural entity. This tumor remains within the cavernous sinus. Come outside, open the dura, work within the cavern, within the cranial nerves, and you can remove this tumor beautifully. And extradural, for the first time in the literature, this was described. More recently, we discussed my personal experience with 45 cases of cavernous hemangioma of cavernous sinus, most of them treated by extradural route. So this is the tumor. I will like to quickly show you the video of this. First, I come extradural, then I dissect between the laterally displaced fibers of the trigeminal nerve. I call it transgasserian ganglion approach, or we can displace the cranial nerves up and down and work within the membranes. I like to demolish the tumor quickly, learn the art of breaking the tumor. Coagulation is not the key for surgery. This is actually a completely unedited tape. And if you realize it is bleeding heavily and I'm controlling the bleeding with multiple suction, I'm working over the carotid artery, sixth nerve is displaced lateral to the carotid artery. You have to come above the carotid artery, identify the sixth nerve early in the operation, and then demolish the tumor. Work quickly. You see, you cannot just spend time in coagulation because there is nothing to coagulate. This artery of inferior lateral trunk of internal carotid artery, you will see now, actually, maybe you can see, you see here is the artery, and first time in my operation, this is quite large in size here, and I am going to coagulate this, and then I am going to work in the tumor. You see, the coagulation has come for the first time. Basically, my technique is breaking the tumor, breaking and demolishing the tumor quickly, rapidly, and then control the bleeding as it happens. More often than not, particularly in tumors like acoustic tumor, there is no need for coagulation. You have to coagulate only very minimally in a very strategic fashion. In this tumor, which is the most vascular tumor in the critical location, you have to just demolish the tumor. And I like to recently say that no cavernous sinus tumor surgery should be done more than 1 hour. You have to quickly remove. If you are spending hours and hours, and this is just, in my estimation, may not be an essential thing. So if you see here the carotid artery, I have not exposed lateral to the cavernous, lateral to the carotid artery and the tumor. And more importantly, you can give new life to the patient. This is another tumor. You see the tumor completely, lateral wall is intact, fifth nerve is displaced laterally, third nerve is displaced superiorly, intercavernous sinus, sixth nerve is in the inferior dome of the tumor. And this is the surgery. I don't want to, you see, it is quite a, I just want to show quickly few steps in the operation. First thing is, this is, you know, working in the red territory. First thing you do is identify the sixth nerve, which I will be doing first. This is, I'm just working within the, in a very bleeding situation. If you are not able, you see the sixth nerve, I have first identified and then control the sixth nerve, and then I am working on the tumor. So sixth nerve is the most critical issue in this operation. Identify it first, and then you get a very, this is the carotid artery, a panoramic view of the whole. And you see here the patient has third nerve, patient has sixth nerve, and after 2 months of surgery, all the cranial nerves have returned. So there is a potential of curing this person. If you know the dural anatomy of this, that they remain within the dura, they displace the nerves, and they encase the carotid artery. This was one tumor. You see huge tumor encasing the carotid artery, going towards internal intercavernous sinus, optic orbit, Meckel's cave, having a flow-related aneurysm. This was clipped by me about 25 years ago, and the tumor was removed. And the person is cured. This is another tumor. You see similar extension. And this is one of the most beautiful chapters of neurosurgery. I want to now take you to giant pituitary tumors and small pituitary tumors and discuss with you the dural anatomy of these tumors. And I have written multiple articles on this subject, and I hope that you can read some of these articles, which are quite wonderful articles in my estimation. So these large tumors some pituitary tumors can become large and huge and massive. You see it massive. But I have to tell you that even if they become large and massive, histologically they are benign, and anatomically they respect the dura. So this tumor, you see this tumor is extending like this. For the first time in the literature, we said that the diaphragm celli is elevated on the dome of the tumor. The information before that, 25 years ago, we described this concept that diaphragm celli dura is elevated like this. Before my description, the understanding was this tumor goes out of the dural rent and comes, and this part of the tumor is subarachnoid, this part of the tumor is intradural. So this concept that the whole tumor is intradural is completely revolutionized pituitary tumor surgery. You see, this is dura, this is dura. The whole tumor is interdural within the confines of the dura. Even when there is a nub in here, it is in the under the dura. This is a very important concept. And if you do not have this concept, you cannot remove these kind of large tumors. So this tumor one has to come from the nose, just remove the anterior wall, and there is dural protection here, diaphragm protection here, and you demolish the tumor, break the tumor, break the tumor, break the tumor, and you will get the entire diaphragm inside the picture. And the tumor resection, you don't have to see the carotid artery, you don't have to see the basilar artery, you have to just learn how to break the tumor. So even when there is a huge nubbin like this, this is within the dural confines, and this anatomy has to be understood. Grade 2 tumors are those which go into the cavernous sinus and encase the carotid artery. The lateral dural wall of cavernous sinus remains intact. The diaphragm celli dura remains intact. So this is also essentially within the dura. Also interdural. This is the lateral dural wall and internal carotid is encased, and this I call grade 2 tumors. So both cavernous sinus are involved, lateral dura is intact, diaphragm dura is intact, lateral dura is intact. We have to understand and know this anatomy. So diaphragm dura is intact, lateral wall dura is intact. Now carefully see this slide. This tumor is going into the cavernous sinus. This part of the tumor has elevated the roof of the cavernous sinus dura. So the whole tumor is still interdural or within the dura. Diaphragm dura, roof of cavernous sinus dura, lateral wall dura. So roof of cavernous sinus dura, diaphragm celli dura. So the whole tumor is within the dura. And this anatomy, if you have, you can remove with a small exposure. Learn the art of breaking these tumors and you can break this tumor very quickly. Many of these tumors are soft and necrotic. So this is the dura of the diaphragm. You see elevation of roof of cavernous sinus dura. So this concept that the diaphragm is elevated was first introduced by us, and the roof of cavernous sinus dura is elevated. So this relationship is very critical if you are going to operate on these tumors. Roof of cavernous sinus, diaphragm, roof of cavernous sinus. So there is a method in madness of these tumors, and this madness has to be understood. When these tumors transgress the dura, encase the arteries, they become aggressive. And the surgery for these tumors is a very difficult chapter of neurosurgery. If you are aggressive in these tumors, you can certainly have a death in the postoperative period. So this is my classification. Grade 1 is when the diaphragm is elevated, no cavernous sinus involvement. Grade 2 is when when cavernous sinus is involved. Grade 3 is when the dura is elevated of the roof of cavernous sinus, and grade 4 is when the arteries of circle of Willis are encased. So this is my classification, and there is no hesitation for me to say that understanding of these dural extensions and limitations have completely revolutionized pituitary tumor surgery. If you do not have this understanding, you cannot remove giant pituitary tumor. Like this tumor, you just have to remove the anterior wall of the sella and break the tumor, break the tumor. I have done more than 5,000 pituitary tumors. And I must tell you that I have never used bipolar in these tumors. Break the tumor, get the tumor into the field. They are never hard like meningiomas. They are soft. Most of them are necrotic. Most of them are highly vascular. Break the tumor and you will get the diaphragm in picture in very quick time. And this is my concept that the uterus pushes the baby down. Dura is the strongest muscle, like uterus is the strongest muscle of the body. Dura is the strongest membrane of the body. It pushes the tumor down. If there is a pregnancy in the pituitary tumor, first get the baby out and the uterus will automatically come down. So break the tumor, only anterior wall of the sella. No need to remove tuberculum celli or planum sphenoidal, whether you use microscope or whether you use whatever you use. But if you have the anatomy that the diaphragm dura is intact, you can remove this tumor. So I removed this tumor in 2001, and this tumor, another big one, quite straightforward tumor. If you are removing this tumor in 5 hours, you have to learn this surgery. This tumor has to be removed in 15 minutes or 20 minutes. And frontal extension was the very clear indication of transcranial approach. But this tumor can be removed. Just open the dura here and remove this tumor. So this is another tumor. Dura remains intact, and you can get from a very small exposure these kind of tumors. So you can see in 2001, 22 years ago, I removed this tumor from the nose. And what beautiful tumor resection. This is another tumor I removed in 1999, just anterior wall. Break the tumor, the whole diaphragm will come into picture. Understanding of the dura, understanding of the cavernous sinus dura, understanding of how the tumor goes, understanding the tumor will make you remove this cavernous sinus part of the tumor. You see how the dural roof of the cavernous sinus is elevated. And when the tumor residue is in the cavernous sinus, you have to give radiation because these tumors are more likely to recur. So elevation of roof of cavernous sinus here, and this tumor is removed. So you have to understand this dural anatomy to remove these kind of tumors. When the artery is encased, this becomes a difficult chapter. And then I'm still studying these tumors to come to a conclusion as to how to remove this tumor. Now I go to another beautiful chapter of my study and how these benign trigeminal neurinomas respect the dura. So this article I wrote in 2003 with my experience of 73 cases. Now my experience is more than 300 cases, which is the largest experience in trigeminal neurinoma. In this article, we said for the first time that trigeminal neurinomas arise within the Meckel's cave dura, and the tumor can go in front and behind, but origin is in the Meckel's cave dura. And we said that this part of the tumor, the middle fossa, is interdural in location. For the first time in the literature, in this article, we mentioned that you can improve the sensation of trigeminal nerve after surgery. It was not mentioned earlier. So working within the dura, we said here in the posterior fossa, it is intradural like acoustic tumor. So work within the dura. But more recently, we have said that even this part of the tumor can be interdural in nature. In 1995, we removed trigeminal neurinoma by just widening the Meckel's cave infratemporal interdural without any craniotomy, 1995. So this was one tumor we removed on the basis of clinical understanding because they have characteristic presentation and characteristic anatomy. So this tumor I removed in 1994, the part of the tumor in the lateral wall of the cavernous sinus, interdural and posterior fossa, by just opening the Meckel's cave and removing this tumor. So this was another tumor in my same article in 1995, which I removed by just understanding the dural anatomy. And this is, we have to know that middle fossa tumor is interdural. Even posterior fossa part of the tumor can be interdural when the tumor is multi-compartmental in nature, but more often it is subarachnoid in location. So earlier these tumors were removed in 2 stages in 1991. Before 1990, this Malice had introduced for the first time in 1985 or 86 about single stage removal of these tumors. But we removed in 1991 in 2 stages. First, we removed the middle fossa component, and then we removed the posterior fossa component. This is another tumor. First, I removed the posterior fossa component and then the middle fossa component in 1992. So about 30 years ago. Then we started for large tumors. We introduced this basal exposure where temporal craniotomy was associated with mastoidectomy. This temporal craniotomy with mastoidectomy was first done by us and published in 1996. And that was my resection of root of zygoma, roof of condyle, roof of external ear canal, partial mastoidectomy was discussed in our article. More recently, I do just splitting of the temporalis muscle and do a small craniotomy over the Meckel's cave, and then work extradural and interdural. For large tumors, I still work intradural, retract the temporal brain for the tumors which are dumbbell shaped in nature. And if you see this temporalis muscle is rotated anteriorly, this was also the first description of this kind. So as I mentioned, we have got several hundred, 300, more than 300 cases of trigeminal neurinomas. Open the dura, work within the tumor cavity, demolish the tumor, quickly demolish without coagulation, and save the fascicles of the trigeminal nerve, and without minimum coagulation, and quick resection is possible in these cases. So this is multiple tumors I'm showing you where we have done very beautiful resection. Even when there is a small nubbin here like this, here in this case, it is interdural. It is never, there is no need to expose the carotid artery during surgery. There is no need to remove anterior clinoid process. There is no need to remove petrosectomy. The tumor itself makes the way for you and you can remove the tumor. We also said when the tumor goes extracranial, it is within the layers of the dura. And this is also a beautiful, so the dura is not transgressed by these tumors, even when it is intracranial, when it is extracranial, and you can do a reverse transcranial. For these kind of tumors, make a small craniotomy, retract the brain, and come extradural and interdural to remove these tumors. So the carotid artery is displaced medially. There is role for transnasal and endoscopic is very minimum in trigeminal neurinomas. Even when the tumor recurs and it becomes massive recurrence, it remains within the dura. So understanding of dura is very critical in the surgery for trigeminal neurinoma. In the surgery for third nerve neurinoma, the third nerve neurinoma arises in the region of oculomotor cistern and it elevates the dura. The whole tumor remains within the dural confines. You don't have to remove the capsule of this tumor. It is not the capsule, it is the dura. Work within the tumor, demolish the tumor, and you can remove these tumors beautifully by working within the dura, and you can save the function of the third nerve, which has never been discussed in the literature. So interdural oculomotor neurinoma. These tumors arise from the oculomotor cistern, and it has a covering of dura. This anatomy is absolutely important. So you see here, this is the third nerve neurinoma. It is completely having a dural boundary. You have to work within the tumor, demolish the tumor without coagulation. And if you don't put too much coagulation, you can save the fibers of the third nerve. And this is the sixth nerve neurinoma. The anatomy of the sixth and the dural relationship of sixth nerve is unclear, but still it is possible to understand this. We are still working on this sixth nerve dura. Seventh nerve arises in the region of Meckel's cave, like trigeminal neurinoma arises in the region of Meckel's cave. Oculomotor cistern, third nerve neurinoma. Seventh nerve arises in the region of geniculate ganglion. And when it grows medial fossa, posterior fossa, it remains within the dura. And if you understand that it remains within the dura, you work within the dura and remove the tumor, you can save the seventh nerve function. Although I have not been able to save the seventh nerve function or improve the seventh nerve function, there is a distinct possibility. At least there is a possibility of quick operation. Don't remove the dura, save the fibers along the seventh nerve. Another beautiful tumor is lower cranial nerve neurinoma. And you see the title, interdural approach to lower cranial nerve. Lower cranial nerve tumor arises in the region of jugular bulb. And when it arises in the region of jugular bulb, it has a complete dural cover in the posterior fossa and extracranially. Work within the dura, work within the dura. In this article of mine, if you read this article, we have mentioned that we were able to improve the function of lower cranial nerve, something which has never been described in the literature. So don't remove the dura. Work within the dura and you can remove beautiful. You see this whole tumor, the cover of this immediate postoperative, it remains, but preserve the dura. Learn to break the tumor and learn to preserve the dura. You will save all the adjoining cranial nerves and the blood vessel. So this is another lower cranial nerve. Another tumor I want to talk about is the C2 neurinoma. C2 ganglion is behind the C12 articulation. It is the only ganglion which is outside the spinal canal. All the tumors which arise from the C2 ganglion are not having any bony cover. They are within the dura. They are like trigeminal neurinoma. They are close to vertebral artery, like carotid artery, and there is a huge venous complex in this location. So my understanding was that this C2 neurinoma, this is C2, is intradural, interdural, like trigeminal neurinoma. But my recent understanding is this article I wrote in the year 2008 with 60 cases. More recently, I wrote my experience with another 50 cases. Earlier, my experience was that this part of the tumor is intradural. But now my experience is that even this part of the tumor is interdural. And you work within the tumor, and you can do a very quick surgical resection in less than 1 hour without any kind of laminectomy or bone work. So this is C2 neurinoma. It looks very much like trigeminal neurinoma. Don't have to do any laminectomy. Here you may avoid all craniotomy, and you can do this tumor resection without any vertebral artery control. A beautiful tumor to resect. Now I come to another tumor, which is a very favorite tumor of skull-based surgeons, is a chordoma. Chordoma is a histologically not so aggressive tumor. Behaviorally it is. So it arises from the bone. It displaces the carotid artery anteriorly. It displaces the cavernous sinus superiorly. It is an extradural tumor. You see, this is a very critical. It is outside the dura. It has the power to destroy the bone, but it does not have any power to destroy the dura. So understanding that the carotid artery is displaced anteriorly, the cranial nerves are displaced superiorly, the dura is displaced. So you can work in this tumor in a very beautiful fashion. This is a huge tumor. So this article of mine in 1995, I am very happy with this. One of my favorite articles where we had discussed that the carotid artery is displaced anteriorly in the anterior. So there is no artery in the middle of the tumor. So work in this direction and you can remove this tumor very beautifully. According to the dural confines, we had discussed this middle fossa subgastrian ganglion approach to clival chordoma. I think it is still relevant in a number of cases, and it is a beautiful, beautiful approach. So this tumor I diagnosed on the basis of carotid artery relationship, that it is a chordoma. The dura is behind. So you come from the middle fossa, work within the tumor, and you can remove in a beautiful, quick fashion. This is another tumor which was removed. So we have got several cases. I just want to quickly show you this video. And you see from the lateral, from the middle fossa perspective, how beautifully you have the arteries under control, the carotid artery, the cavernous sinus nerves, and you can remove this tumor under very big, beautiful control. Although endoscopic transnasal approaches are becoming popular, but I feel that transcranial route has a beautiful relevance in many of these chordomas. More recently, I described supracerebellar approach to clival chordoma. Supracerebellar approach. A beautiful, you see this tumor, you can come from the nose, you can come from the middle fossa, but large part of the tumor is in the posterior fossa. More important is that the sixth nerve, which is the most dangerous nerve in the chordoma, is displaced along the posterior dome of the tumor. And you come from here, identified for supracerebellar, you make a dural incision. This tumor is extradural, make a dural incision, work within the tumor, identify the sixth nerve, and you can remove this tumor by a very quick supracerebellar route. So this tumor, also chordoma, we didn't know it was a chordoma, supracerebellar, and resected. This is another chordoma, supracerebellar route, and beautiful resection. So supracerebellar approach for these kind of tumors is a very relevant approach in my estimation. Paranasal sinus tumors remain many of these like nasopharyngeals are extracranial tumor and they are extradural tumor, nasopharyngeal angiofibroma. So we had discussed a transcranial approach for these tumors. They remain outside the dura and outside the skull. So although we described transcranial route in 1994, but now I prefer transnasal route for majority of nasopharyngeal angiofibromas, it is a good approach. Cavernous sinus can be involved by trigeminal, by epidermoids, by aspergillomas, by tuberculomas, and my last discussion will be on meningiomas. Meningiomas are tumor of meninges. They are tumor of the mother dura. Like this tumor is a convexity meningioma, it does not involve the superior sagittal sinus. This tumor is little bit involving the superior sagittal sinus. So this tumor is more benign than this tumor. This tumor is more aggressive than this tumor. This tumor involves the superior sagittal sinus and this tumor involves the bone. This is more aggressive, inherently more aggressive. This tumor involves the paranasal sinuses. It is more aggressive. We have to understand that this is a meningioma, all right, but it is involving the paranasal sinus. It is more aggressive. And when the meningioma is primarily in the paranasal sinuses, it is more aggressive in nature. Similarly, when the cavernous sinus tumors are inside the cavernous sinus, they are inherently more aggressive. When it is on the wall of the cavernous sinus, it is a benign, like a convexity meningioma. So this tumor is not entering into the cavernous sinus, it is a more benign tumor. This tumor is entering into the cavernous sinus, it is an inherently aggressive tumor. This tumor is going into the paranasal sinus. This meningioma is like a malignancy. So intracavernous sinus meningioma there is propensity to recur in a very frequent fashion. So this tumor I had removed in 1995 and there was a recurrence in 2001. Similarly, this tumor I had removed and there was a recurrence after some years. So these primarily intracavernous sinus tumors are more aggressive. Tumors which go into paranasal sinuses are like malignancy. Tumors which remain on the wall of the cavernous sinus are benign. So this tumor from the posterior wall getting supply is a benign tumor and long-term cure can be obtained. This is another tumor from the posterior wall. You remove it radically, you can cure the person. This is another tumor from the wall, not inside. These are very histologically benign. So earlier in my exposure, in my development of neurosurgery, my exposures were very big and huge. Mobilization of facial nerve, mobilization of carotid artery. But now my exposures have become much less. And for petroclival tumors, for the first time, we described supracerebellar route for the first time. Of course, CP angle and acoustic tumors, Dr. Sami had discussed posterior fossa approach and all those things for petroclival meningioma, but supracerebellar approach was discussed for these meningiomas for the first time, and we are using supracerebellar approach. This needs sitting surgical position and a beautiful possibility of removing these tumors quite radically by supracerebellar surgical route. So you can have this exposure and then go along into the middle fossa. This tumor also removed by supracerebellar route. You can see the anatomy after resection of this tumor. This is another tumor, small residue, but I have given any radiation. And this is another tumor. I will quickly show you the supracerebellar surgical route and having a very beautiful exposure from this kind of with very quick exposure. So supracerebellar approach is a very beautiful approach for these tumors, and we have done several. So we have got the advantage with me was working in a public hospital where we had operated all the time in my life, went into surgery. So this was my experience with 70 tuberculum cell meningiomas in 2002. Now my experience is more than 300 cases like trigeminal neurinoma. This olfactory group meningioma, 129. Personal experience also, I think, is amongst the largest experience reported. Foramen magnum meningioma is another beautiful tumor. Our experience is quite big in this, and initially we were doing all foramen carotid vertebral artery mobilization, condylar resection. Then we discussed about just posterior fossa, midline exposure, working within the cranial nerves, learning the art of demolishing the tumor and breaking the tumor. More recently, I discussed ossified, the most difficult neurosurgical tumor, This was in front of the brainstem and ossified. You see complete bone. And I removed with very minimum midline posterior foci exposure. This is another tumor, complete bone, vertebral artery within the tumor, and was completely removed with minimum midline exposure. Another tumor, complete ossification, and this is postoperative tumor resection. So what my feeling is, understanding the tumor, understanding the art of the breaking of tumor, understanding the philosophical understanding of the nature of the tumor makes you do good neurosurgery, makes you do philosophical neurosurgery. We must remember that if our patient is damaged by surgery, it is not the tumor which is at fault, it is we who are at fault. We should know that curing is a non-issue in the treatment of, we don't ever cure a meningioma. We just treat a meningioma. Another very beautiful issue is recurrence of meningioma is independent of extent of tumor resection. I don't believe Simpson grading and all those things are important, but it is very important to understand that it is not treatment, but the cellular behavior of the tumor which decides the outcome. So thank you very much, my dear friends. I hope I have been able to give you some beautiful new information on these complex tumors. Ben, over to you.
Okay, great. Thank you. There's a question from Qiantang Hospital, Professor Jia Wenqing. He asked about the gamma knife to treat the cavernous sinus hemangioma. Do you use it, gamma knife, or surgical radiotherapy for this kind of tumor?
See, cavernous hemangiomas of cavernous sinus are more difficult neurosurgical problems. They are not easy. They are dangerous. It is not easy to operate. So the radiation treatment was, many articles were written about gamma knife for cavernous hemangioma, and the earlier experience was not very positive about gamma knife and radiation for cavernous hemangioma. Recently, there are some reports from various parts of the world that gamma knife is effective treatment for cavernous hemangioma. So if it is effective, it will be very good for the patient. But, you know, many of these patients come with very severe headache, and many of these patients come with eye movement disturbance. So if you are if the person is having severe headache and you give gamma knife, the result may or may not come after 2 years or 3 years. You know, the response is not quick in gamma knife surgery. So I'm not sure, I don't have much experience, but I do know that many groups are now talking about gamma knife in cavernous hemangioma, I know, and we should wait for their experience. Ben.
Yeah, you know, in our hospital, this kind of tumor was treated by cyber knife and gamma knife. Now I think the dose of the treatment is crucial for the shrink of the hemangioma. Yeah, not so high as the normal tumor.
Yeah.
Yeah.
So we will have to wait and see the results of this gamma knife.
Yeah. Any questions from the audience?
Good day, Ahmad. How are you? From Afghanistan. Say, how you doing? Oh, you're muted. You're muted, Ahmad. You're muted. You're muted. Well, no.
Okay.
Unmute.
Thank you.
Yeah.
Thank
Yes.
you, Professor Atul. Nice to see you again.
Thank you.
That was
Thank you.
great presentation. Yeah, that was really good. And congratulations for your achievement. Yes, we're proud of you.
Thank you. Thank you. Thank you. Victor, I want to hear from you. Victor.
Hello, Professor Atul Goel. This is an inspiring talk. I think this kind of work that you have done around the years is a very nice example for all young brain surgeons around the world. You are doing a really, really amazing job. Congrats, and hope to see you here in Mexico next year. So maybe at the on November next year, we will be very nice to see you here in Mexico. Also, Dr. Binshu, all the stars in Mexico next year.
Thank you. Thank you. Binzu
I
will
think
come
Professor Atul is a artist. He is just like more complex the tumor, he would be more joyful. And maybe when removing the tumor, he will sing a song. Yeah.
Arshad, do you want to check in? Go ahead, Arshad.
Takashi is there. Takashi.
Takashi.
Thank you, Dr. Goel. The wonderful lecture. And I'm so impressed of the removing a large tumor beautifully. And I hope that I mean, our experience very large cavernous sinus tumors sometimes dangerous to remove. So we are partial removal and gamma knife and radiation. So for fear of bleeding, but I learned a lot from your presentation. And like in uterus, that kind of feeling sometimes I feel, but sometimes I cannot understand the situation due to struggle with bleeding. But I learned a lot and a very informative lecture. Thank you, Dr. Goel.
Thank you, Takashi. Thank you so much. Harshad?
Okay. Samuel Morsi, how are you doing today? From Egypt.
Unmute, unmute.
Okay, well, I believe
Harshad, unmute. Harshad, unmute.
Okay.
So I have a question, Professor Goel. You grade the adenomas in different grading, and if the adenoma invaded into both sides of the cavernous sinus, would you want to achieve the single session to remove it all, or just take both side operation?
See, Ben, it is very important to understand pituitary tumors and to understand when to remove the part in cavernous sinus. Whether to remove, whether, many times, when it goes into cavernous sinus, they are non-functioning tumors and you may not like to remove, because there is a possibility of cranial nerve damage and things like that. But many of these tumors are very soft. Pituitary tumors are soft, particularly those which are going in the cavernous sinus are soft. You just widen your medial exposure and you can just use gentle suction and you can remove these tumors. But if the tumor is not a non-functioning tumors, I have a feeling that aggression within the cavernous sinus should not be too aggressive. We should not be too aggressive in non-functioning tumors. Of course, when the tumor is functioning like Cushing disease and other, like for acromegaly, if you don't remove, the results are not good. So in that case, your medial exposure, medial wall exposure, then working around the carotid artery, working around the sixth nerve, and those things are very important. But you have to, working in cavernous sinus for pituitary tumor is a very, philosophical, more than technical. It is more technical than also philosophical. You understand what I'm saying, Ben?
Yeah. Okay, great. Thank you so much. And it's a really fantastic presentation. And Professor Yuan Li.
Hi, yeah, this is Yuan Li.
Yeah.
Thank you, Dr. Goel and Dr. Bing. So now we should move to next speaker from mainland China, Dr. Yiqiang Zhou, and he's a neurosurgeon from Beijing Xuanwu Hospital from Capital Medical University, also one of the largest neurosurgical center in China. And today he will talk about clinical trials of target therapy for IDH mutant gliomas. So please, Dr. Zhou.
Yes.
Dr. Zhao, are you muted? Hello, Dr. Zhao? You're muted. You're muted. Juan Lee.
Dr. Zhou, I'm not. I think he already started the screen, share the screen.
Yeah, he's
Dr.
got the
Zhou.
screen, but we don't have a voice.
周大夫，周教授，你的静音了吧 ？Dr. Zhou.
I don't hear any audio.
Let me see if I can contact.
Oh, so you're presenting for him? Okay.
No, I cannot do it.
Oh, okay. I thought maybe you were just.
Maybe just 1 minute.
Okay.
Let me see if Dr. Zhou. There's some problem with Zhou. I can contact him by WeChat, but I'm not sure.
It looks like he's connected here. I can see him trying to speak. And the
Maybe
camera's working and the
maybe some problem with his internet connection.
okay, because I see him. Dr. Zhao, can you hear me? Can you just text if you can hear me? Okay, he's starting the screen share. Okay. I think he's experimenting, going off. Yeah, he's on mute. There he's off mute. Okay. Okay, Dr. Zhao, are you there?
Yeah, I'm here. Can you hear me?
Excellent, excellent. Could you please introduce yourself? Welcome.
Thanks. Thank you very much. Thanks for Professor Zhao's introduction. And I am a young neurosurgeon from Xuanwu Hospital, Capital Medical University in Beijing. And thanks for the presentation from Dr. Goel. I've learned a lot from you. Very great work. And today I'm very nice to meet you here to talk about IDH mutant gliomas and its targeted therapies. Their current advances. And IDH mutant gliomas account for more than 80% of WHO grade 3 and 4 astrocytomas, oligodendrogliomas, and more than 50% of secondary GBMs. and it tends to happen in younger patients with better.
I think the internet. Just hang on. I think the internet may be a little slow. Just wait. Can you hear me, Dr. Zhao? I think that's why we had sound problems before. The internet is not well connected.
I think it's because of his connection is very poor, and
yeah, that causes issues with sound. Hopefully he'll reboot and come back in. Is anybody communicating with him? Wan Li, are you communicating with him?
Yeah, I can talk. I still can contact him with the WeChat, but
Even WeChat, if you can tell him to just reboot and come back in, that's the only thing we can do. Because it looks like it's unless he can send you the PowerPoint. But can you show his PowerPoint, Wan Li, or no? Oh, okay, he's trying again. Okay, let's try to give it another shot. Maybe we'll get lucky. Okay, keep your fingers crossed. Dr. Zhao, can you hear me? We have a chance if we can just get on there. Oh, okay. Dr. Zhao? Can you hear me okay? Hello, Dr. Zhao, you're muted. Can you hear me, Dr. Zhao? Wan Li, if you can tell him he's muted.
Yes, I just send WeChat talk to him, but
okay.
But there's no play and no reply. I'm not sure.
Yeah,
maybe
if I could get him to turn his camera off, save bandwidth. Do you know what I mean? Like right now, I'm gonna turn my camera off. And you see me, Wan Li? I turn my camera off. That saves bandwidth. If we can communicate to Dr. Zhao that fact. Do you know what I mean, Wan Li?
Yeah, I talked to Dr. Joe and he said he's in the hospital and there's 5G internet. I'm not sure why there's some problem, but maybe just wait a few more minutes, see if it's
okay. Maybe we'll get lucky.
Yes. Anyway, yeah.
We'll just wait. We'll just wait. Maybe he'll hook up. I'm sure he's working on it. looks like. Okay. Now both the camera and sound are turned off. Dr. Zhao, can you hear me at all? No?
Hello, can you hear me?
Yes, we can hear you now.
Oh, that's great. Sorry for the poor signal.
Okay, now you need to screen share.
Okay, okay. Is that okay?
No, you're not screen sharing. It looks like
Okay. Thank you very much. Sorry for the poor
I'm
signal.
sorry, you're still not screen sharing. I'm sorry.
Can you hear me?
Yes, we can hear you, but we can't see your PowerPoint.
Oh, sorry.
Yeah, please share it.
Okay.
Well, I'll let you know when it comes on. Okay, you're on your way. Okay.
Okay, you can.
There you go. Make it big.
Okay.
Make it big.
Yeah.
Okay, you're
Sorry
ready.
for the poor
Ready.
signal.
No problem. Let's give it a shot.
Okay, thanks very much. I'm sorry. And dear professors, colleagues, it's very nice to meet you here to talk about mutant IDH mutation, IDH mutant gliomas and its targeted therapies. And IDH mutant gliomas account for more than 80% of WHO grade 3 and 4 astrocytomas, oligodendrogliomas, and more than 50% of secondary GBMs. It tends to be happen in younger patients with better chemosensitivity and long prognosis. And the PFS1 is 5.7 years and PFS2 is 3.1 years. And currently there are no effective therapy have been confirmed to prevent recurrence, progressive, and malignancy transformation. And IDH mutation leads to the increase of D2-hydroxyglutate, it's D2-HG. High levels of D2-HG can inhibit alpha-KG-dependent dioxygenases, including histone and methylate and DNA demethylases. Overexpression of mutant IDH enzymes can induce histone and DNA hypermethylation, as well as block cellular differentiation, which can be reversed by small molecule inhibition of the mutant enzymes. And currently, there are 45 clinical trials for IDH mutant gliomas worldwide. And there are totally 33 clinical trials of targeted therapy for IDH mutant gliomas. Most of them are in recruiting status. This figure shows the trend of clinical trials of targeted therapy for IDH mutant glioma from 2015 to 2022, and most of them were in US. And during my postdoc program in NCI NIH, there were at least 2 clinical trials for IDH mutant glioma ongoing in the medical center. And there are 12 phase 1 trials, 17 phase 2 trials, and 1 phase 3 trial. 5 of them have completed. Basically, there are 5 kinds of targeted therapies for IDH mutant gliomas. They are IDH inhibitor, mutant IDH enzyme vaccine, PARP inhibitor, and anti-PD-1, PD-L1, and demethylation agent. These are the targets in the IDH pathway. And the first clinical trial I want to introduce is the ivosidenib in IDH1 mutated advanced glioma. ivosidenib, AG120, is a highly selective inhibitor for mutant IDH1. This was a multi-center open-label phase 1 dose escalation and expansion study conducted made by Dr. Mellinghoff from Memorial Sloan Kettering Cancer Center. Ivosidenib was administered orally daily in 28-day cycles. And AG120 is a highly specific and reversible inhibitor of mutant IDH1 that competes for binding with the mechanism, iron, and crucial enzymes for a cofactor, preventing the formation of catalytically active site. And despite a low rate of brain penetration in rats with an intact blood-brain barrier, AG120 showed a robust tumor and time-dependent D2HG depletion in a mouse mutant IDH glioma xenograft model. And the pharmacokinetic analysis revealed that AG120 was detectable in the brain and the brain tumor tissue of the mice, although at much lower exposure than in the plasma, indicating that AG120 is highly potent against the mutant IDH protein in vivo. And in 66 patients with gliomas, 32 were WHO grade 2, and 18 were grade 3, and 12 were grade 4. 49 patients have received prior radiotherapy. 20 patients were treated in dose escalation phase, and 46 were treated in dose expansion phase. Most patients experienced at least one adverse event of any grade. The most common adverse event were headache, nausea, fatigue, vomiting, seizure, and diarrhea. Hello. Hello, am I still with you?
Yeah, we can hear now. It's good.
Okay, I'm sorry for that interruption.
Okay.
And most patients experienced at least one adverse event of any grade. The most common adverse event were headache, nausea, fatigue, vomiting, seizure, and diarrhea. And grade 3 adverse event was observed in 13 of the 66 patients. These included a headache, hypophosphatemia, and seizure. No patient required dose reduction or discontinued treatment due to adverse event. And 35 patients with non-enhancing tumors had a median treatment duration of 18.4 months, compared with a treatment duration of 1.9 months for 31 patients with enhancing tumors. And in patients with measurable disease at baseline, a tumor measurements decreased from baseline in 22 of 33 non-enhancing tumors and in 9 of 27 enhancing tumors. The median PFS time were 13.6 months and 1.4 months for the non-enhancing and enhancing glioma cohort, respectively. The majority of patients had disease control with a best response of stable disease observed in 30 of 35 patients with non-enhancing tumors and 14 of 31 patients with enhancing tumors. And here are some examples. The patient 1 had an anaplastic oligodendroglioma that was initially treated with surgery, radiation, and TMZ. And patient 2 had an astrocytoma and had undergone tumor resection 6 years before enrollment and had received no additional therapy in the interim. MRI showed the increase in tumor volume before enrollment, and visual inspection of co-registered images and the volume curve showed tumor shrinkage after initiation of AG120.
Respectively. The majority of patients had a disease control with a fast response of stable disease observed in 13.
Patient 3 had an oligodendroglioma diagnosis 4 years. And patient 3 had an oligodendroglioma diagnosed 4 years before enrollment and was observed without additional therapy since the initial surgery. And treatment with AG120 resulted in reduction of tumor volumes. And patient 4 had an oligodendroglioma diagnosis by biopsy 8 years before enrollment, and was initially treated with surgery and 1 year of temozolomide, and then was observed for 7 years without additional therapy. The gradual increase in tumor volume before enrollment stabilized after initiation of AG120. This trial suggested that AG120 has greater activity against non-enhancing gliomas than against enhancing gliomas. They also hypothesized that AG120 may be more effective in non-enhancing gliomas because the tumors represent an earlier disease stage with fewer genetic alterations. This is a second trial. It is varosidenib, a dual inhibitor of mutant IDH1 and 2. Varosidenib is a first-in-class brain-penetrant dual inhibitor of the mutant IDH1 and mutant IDH2 enzymes. It was a multi-center open-label phase 1 dose escalation study of varosidenib in 93 patients with mutant IDH1 and 2 solid tumors, including 42 patients with glioma that had recurred or progressed following standard therapy. This trial was conducted still by Dr. Mellenhoff from Memorial Sloan Kettering Cancer Center and Dr. Clovesy from UC Area Medical Center. A preclinical study showed that varosidenib could inhibit more than 97% of 2-HG production in mice brain with IDH1 mutation. The glioma cohort included 22 patients with non-enhancing glioma and 30 with enhancing glioma. The median age of the patients with glioma was 42.5 years old. No patient with enhancing glioma had a confirmed radiographic response, and 17 of 30 patients had a stable disease at their best response. And the median treatment duration was 22.8 months for non-enhancing glioma and only 3.3 months for enhancing gliomas. 15 patients with non-enhancing disease and 4 with enhancing disease remain on treatment for more than 1 year. And no patient with enhancing glioma had a confirmed radiographic response, and 17 of 30 had a stable disease at their best response. The median PFS in the overall glioma population was 7.5 months. In patient with non-enhancing glioma, the median PFS was 36.8 months, but in patient with enhancing glioma, the median PFS was only 3.6 months. Visual inspection of the images as well as tumor size and volume measurements showed tumor shrinkage after varosidenib treatment in these 3 non-enhancing glioma patients. In this trial, the tumor shrinkage was only observed in non-enhancing glioma patients with varosidenib treatment, and no indication of anti-tumor activity of varosidenib in patients with enhancing tumors. It may be due to the presence of additional genetic alterations in these tumors that can bypass the need for mutant IDH enzyme for tumor maintenance. the above two clinical trials for mutant IDH enzymes indicated that chemotherapy or radiotherapy may not be the perfect treatment option for non-enhancing glioma with IDH mutation, because chemotherapy or radiotherapy may exert acute and long-term toxicities and additional genetic alterations. And this conversion may eventually lead to the ineffectiveness of targeted therapies. So the Indigo trial had been conducted. It was a multi-center randomized placebo-controlled phase 3 study comparing the efficacy of varosidenib with placebo in patients with residual or recurrent mutant IDH1 or 2 WHO grade 2 glioma who have not yet received the previous radiation or chemotherapy and are under radiographic surveillance from surgery. And this recruitment of this trial is close to being completed, and results will inform us on the ability of IDH mutant inhibitors to prevent the evolution of LGG towards higher grade forms. The third trial is a vaccine targeting mutant IDH1 in newly diagnosed glioma. The study ran from May 2015 to November 2018 at several trial centers in Germany. This was a non-controlled open-label single-arm multi-center first-in-human phase 1 trial to assess the safety, tolerability, and the immunogenicity of 8 repeated doses of IDH1 vaccine in patients with IDH1 mutation, grade 3 and grade 4 gliomas. A treatment consists of 8 vaccinations with IDH1 vaccine in weeks 1, 3, 5, 7, 11, 15, 19, and 23. The trial population was divided into 3 treatment groups on the basis of standard of care treatment that patients had received before enrollment, and radiotherapy alone, 3 cycles of chemotherapy with temozolomide alone, and the combined radiochemotherapy with TMZ. Most patients had radiochemotherapy with TMZ before IDH1 vaccination. 29 of the 32 patients had treatment-related adverse events, none of which was severe. 1 patient had a treatment-related serious adverse event. Of the 30 patients in the immunogenicity dataset, 22 displayed IDH1 vaccine-induced immune responses, and T-cell immune responses were observed in 26 patients and B-cell immune responses in 28 patients. And 2 patients developed neither T-cell or B-cell immune responses, and they showed the tumor progression within 2 years. And this is a pseudo progression. Pseudo progression occurred in 12 of 32 patients. Brain imaging is indicative of intratumoral inflammatory reactions, and there was no apparent association with age, extent of resection, standard of care treatment, or WHO grade. And the pseudo progression was associated with the onset of peripheral IDH1 vaccine-induced immune responses. It was restricted to patients with transient or sustained T-cell immune responses. And no pseudo-progression was detected in non-responder patients. And patients with pseudo-progression had a higher maximal levels of peripheral IDH1 vaccine-induced T-cell immune responses than patients who had progressive diseases. Other targeted therapies are anti-PD-1, PD-L1, demethylation agents, and the PARP inhibitors. They are still ongoing trials. And we hope that more and more clinical trials of targeted therapies will be conducted for patients with IDH mutations. And unlike GBMs, I think IDH mutant gliomas is the most promising type that may be cured in future, which with targeted therapies after maximal tumor resection, we may eventually prevent the IDH mutant glioma patients from recurrence and malignancy transformation. Thank you. That's for my presentation.
Thank you, Dr. Zhou, for your nice talk and many new updates about the clinical trial information for the glioma. So, are there any questions from the audience or panel? I'm not sure. I saw something from the. Some question. No.
Did you have a question, Wan Lee?
No, I don't see any question.
Oh, okay. I believe we have someone there on Ahmad. Do you have a comment or question, Ahmad?
I have a question, Dr. John Bennett.
Go ahead, Victor.
Professor, when do you think countries with low economy are going to have this technology? Because I think this is very good for patients with glioma tumors, but most of the countries do not have this very nice technology. What do you think about that?
Did you get that question, Dr. Zhao?
Sorry, I have the poor signal. I didn't hear that.
Okay, repeat. Can you repeat that? The question is, will this what do you think about this technology in countries that are low development, third world countries? Do you think it'll ever come to the third world, this type of technology?
You mean the
Well, we should be lucky you got through the presentation. Looks like we're having trouble here with the audio here.
Again,
we lost him again.
Some high technology may be expensive at the beginning, and then it will become cheaper and cheaper. Yeah, later. So.
Okay, that's good. That's good. Okay, any more comments, questions? I think we'll wrap this up. Thank you, Dr. Zhao. We're having a little trouble with getting through, but thank you for your time and the effort. And thank you, Ben. Any closing words, Ben?
Yes. Tonight we have around 700 audience from the WeChat.
Oh, excellent.
Wow.
Excellent.
That's a
Thank
lot.
you. Thank you. So, okay, Dr. Goel, I'll tell Dr. Goel he had to go.
Yeah.
So, okay, thanks for everything, Ben, and thanks, Wan Lee, and thanks for the audience for coming, and we'll see you in 2 weeks.
Yeah, that will be October 30, right?
Right. A Sunday, same time, same channel.
Sunday.
Okay, we'll see you then.
Okay, see you.
Okay. Thank you.
Thank you.
I didn't think we were going to get through that, Ben. Well, what's that? That's someone's.
Yeah, next time I will mention to the Chinese speaker about the internet connection. So maybe they can try to connect it first. I know Dr. Zhou, he used the internet from his hospital. Maybe there's some restriction for the in the international connection.
Oh,
I'm not sure. Maybe the hospital internet, there may be some extra limitation for international connection, I guess.
Yeah. Yeah, that was weaker than most. If it came from the hospital, he probably didn't have the best connection. They didn't give him the best connection. We were lucky. We were lucky we got through there.
Yeah. And then next time I will remind the Chinese speaker about the international internet.
It's easy to forget. It's easy to forget. I forget to mention it. But definitely it would improve things. So thanks, Wan Lee.
Actually, October 30, being Dr. Xu, is that ACNS meeting still on Sunday or just finished? I'm not sure. So I'm not sure if we should postpone the webinar 1 week later. I'm not sure.
But just think about it and let me know.
Bing is not here, right? Okay, I will ask him.
Yeah, just let me know. That's all.
Because that weekend that will be the ACNS meeting, Asian Congress of Neurological Surgery.
Where is that this year? Is that in Beijing?
No. It's supposed to be held in Shanghai, but actually I don't think any speaker from other country can come. Just as Professor Xu said, there's still 7 day plus 3 day, actually 10 days quarantine policy in China for all the foreigner. All the traveler from foreign countries. So I don't think
makes it difficult. Yeah.
Yeah. If anyone really wants to come, they need to be here 10 days early before the meeting. So I don't think they like that. And all the whole 10 days they will stay in the hotel room.
Well, so that's that 10-day quarantine. You have to stay in your room. You have to stay.
Yeah, I know there's still very few neurosurgeons. Last year, Professor Batlanfe from Hanover,
Vancouver,
the German neurosurgeon Helmut Batlanfe. He visited Shanghai in that's last year. So I think he also need to be quarantined for 2 weeks, and then he spent 2 or 3 weeks to give some lecture and also do some surgery there in local hospital. And Dr. Yuha, I'm not sure if he returned from Finland.
No, I don't think so. I think he's still in Finland. I don't know for sure, but he is getting more visible on the internet. He did a conference in Turkey. He just did one.
Because he's still appointed as a professor of Henan Medical University, something like that. I don't know. Never mind. Yeah. Okay.
I wanted to ask you. Do you want me to ask you?
Okay, I will ask Professor Xu, Bing Xu, and if he prefer to postpone the webinar 1 week later, so maybe we can have it in the early November. Anyway,
Okay, that would be fine. That's okay.
Yeah, I know. Okay.
Thank you. Thank you, Wan Lee.
Thank you.
Professor John.
Bye.
Hey, Ahmad, how you doing?
Yes.
I also have presentation and ACNS and China, and it's a virtual presentation.
Yes, because there's still
I hear your comment.
Still strict regulation about the COVID-19 quarantine. So even the local neurosurgeon, I think we cannot travel to Shanghai unless
Okay.
there's some
Yeah, okay.
very
You
special
can do my
condition.
presentation virtual online. Yes.
Yes. Okay.
I'm
Thank you.
sorry, Ahmad, what'd you say, Ahmad?
Yes, I told that I have also presentation and SNS China, and it's a virtual presentation about overview of neurosurgery in Afghanistan.
Oh, okay, you're gonna do a presentation. Oh, excellent.
Yeah, wonderful. Yeah, I think
Yeah.
we have already sent the invitations for the virtual presentation to all the speakers there.
Yes,
I guess we still have more than 100 speakers from all around not only Asia but all around the world.
Yes, yeah.
Okay,
Well,
wonderful.
are you involved in running it? Are you running it, Wan Li? You
No,
helping?
Professor Xu, the local organizer, all from the Shanghai Huashan Hospital, Professor Xu and his colleagues. They are the local organizer. But I saw the whole scientific problem, the program, the arrangement already.
I would
fixed.
like to televise it on Neurosurgical TV if he wants to.
Yeah. Anyway.
Okay, Wan Li, let him know. I can televise it if he wants.
Oh yeah, I will ask her, Professor Xu. I think he like to do that.
Okay, we can do it in Chinese too. If he wants to do it in Chinese, we'll do it.
Yeah, wonderful. Yeah, I think I'm quite sure he has some idea. Yeah.
Okay, just contact me. I would love to talk to him.
Sure. Okay, so how's the weather in Miami Beach?
Oh,
still
beautiful,
hot?
beautiful.
Okay.
Beautiful.
Okay.
It's not hot. It's warm, very warm.
Oh, warm. Okay.
But it's marvelous weather. I just love walking around here. It's beautiful. It's beautiful.
Okay, so the hurricane, there's no influence
No,
for your
the hurricane.
area.
Yeah, the hurricane. They come this time of year, but this year it hit Tampa on the other side of Florida. It hit Tampa pretty badly. But this even though it's not that far, it's only 4 hours away. All we had was like a windstorm. That was about it. No rain damage. Nothing serious. They can get serious if they hit you directly, but it has to hit you pretty directly, like Andrew did. Every 10 to 20 years, we have a bad hurricane. You guys have typhoons, right? Do you have typhoons in Beijing or no?
Beijing is not near the ocean, so there's no typhoon. But Shanghai, some city along the the west coast of Pacific Ocean, there's some typhoon. Yeah.
Oh, okay.
Yeah, but Beijing about 200 miles from the ocean,
Oh,
so there's
I didn't realize that. It's 200 miles from the ocean. I didn't realize that.
Yeah. Beijing is not a beach city.
No.
Yeah.
No.
Okay. Yeah. Thank you. So let's keep in touch.
Okay. Thank you.
Yeah.
Thank you.
Okay. Bye-bye.
Bye-bye.
Okay. Thank you. Bye-bye.
Yeah, Ahmad, that's great. You're speaking in China. That's great.
Yeah. Thank you, Professor. Okay.
So did you meet them through coming to this?
Yes.
Oh, the neurosurgeon met you online that invited you to speak in China?
Yes.
Excellent.
Thank you, Professor.
Excellent. Well, we're going to try to televise the event, so maybe we'll see you on Neurosurgical TV.
Yes, yeah. Thank you, sir. See you then.
Okay, Hani, you there? Hani Bolanos from Nicaragua and Sylvia. They wanted to meet a few people. Hani, you there? I see Dr.
Yes.
Yeah, Dr. McLaughlin, how you doing?
Hi, John. How are you?
How you been? I wanted you to meet a resident from Nicaragua. Her name is Hani Bolanos. Hani, you there? She may have
Hola,
stepped away. Oh, okay, there she is. Say hello to, okay. Hello, Doc, introduce yourself, please.
Hello, honey.
hello, how are you?
I'm fine.
Nice to
Thank you very
meet
much.
you.
Thank you
I
very much.
speak this very nice
Thank
English.
you very much. Thank you very much.
Okay, nice to meet you.
Could you identify yourself, please? Dr. Al McCaffrey?
Yeah, I'm McLaughlin. I'm living in Germany. I'm a neurosurgeon here, like in the last 20 years, and working in Wolfsburg, where we are the most production of cars in Germany.
Oh, wow, BMW, right?
Now the Volkswagen.
Oh, Volkswagen.
Volkswagen, we have like more than 63 different kind of cars, Audi and Volkswagen and Porsche and a lot of them.
Oh, okay.
They are also our main production center here in Wolfsburg, and they are like daughter companies.
You know, when I went to Latin America, I was amazed at how many Volkswagens they have, right, honey? Yeah. In Latin America. Yeah, the old bug, you know. I don't see too many bugs around here in the States. I used to see them. I had one myself. I loved it. I always had a Volkswagen until they really stopped making the bug. You know what I mean? But the bug, right?
Yeah, I know. They stopped it. They have now Golf. The Golf replaced it.
Oh, okay.
So it's also like medium size, economic, and for everyone.
Oh, okay.
So the box is the old tradition, and it was like the last they produced is 2003, 2004.
Yeah, I loved it. I always had that Volkswagen until they stopped making it. And then I bought a Rabbit. I don't know if they make the Rabbit still.
Yeah, no,
it's the Golf now. Okay, I guess they don't make the Rabbit anymore.
Golf and Passat.
Okay, very good. Okay, Victor, are you there?
John, I'd like not just to tell you, it's a very nice idea to show the Congress in Shanghai of the TV.
Yeah.
Hello, John. Hello.
Yeah, I'll get to that question later. Hey, Victor, how you doing?
Fine.
I think you know Hani. I think you know Hani Bolanos, a resident from Nicaragua. Oh, Hani, say hello to Victor, one of the most prominent neuroanatomists in the world, especially about Latin America.
Hola, amigos de Nicaragua. ¿Cómo están?
Hola, Dr. Hugo.
Hola, ¿cómo estás? ¿Cómo te va? Bien.
Sí, ella organiza el grupo de Nicaragua con muchos residentes.
Excelente. Espero estar por ahí con ustedes. Sí me he dado cuenta, nada más que últimamente he estado preparando el trabajo para llevar a Atenas, Grecia, y se me ha dificultado el tiempo, pero felicidades por la iniciativa de tener esto ahí en Nicaragua.
Sí,
muchas gracias, doctor.
Qué suerte él tiene, Hani, para ir a Atenas. Museos. Wow. 5 días, ¿verdad, Victor? Paseando por museos y Grecia.
Sí.
Tú vas a la isla, tú vas a poco islas también.
Sí.
Mykonos, tal vez Naxos, tal vez Santorini.
Sí, lo más probable.
Sí, es lo más famoso, yo creo, de las islas, Santorini.
Sí.
Pero sí, Hani está en guardia. Y Ahmad está allá de Afganistán. Ahmad, ¿tú encuentras Victor?
Ok. Assalamu alaikum al-Mukhalifi.
Hello.
Hola, gracias.
From Afghanistan.
Yeah,
Hey, mira, Mira, Victor, él encuentra un hombre de China, él está presentando en Shanghai. Aparte de esto, es presentando virtualmente de Afganistán a Shanghai.
Yeah. Yes, I know. I heard him about that.
Okay.
Yes, I think it's going to be on November. Think so.
Noviembre, Ahmad?
No, in October 30.
Okay. Nice. Very nice.
Okay, thank you.
Hope
Gracias.
to see you. Hope to see you.
Okay. Thank you. Gracias.
Okay, thank you. Have a good day, everybody.
Okay, Dr. Al-Makhalifi. Dr.
Okay.
Al-Makhalifi.
I'm sorry?
Dr. Al-Makhalifi.
I don't understand. I'm sorry, Ahmad, I don't understand. What'd you say?
Yes, here was Al-Makhalifi from Germany.
Oh, okay. Where did he go?
Okay, he left.
I think he left.
Yes, okay. Okay, see you then.
Okay, signing off. Bye-bye.